Hello and welcome. My name is Tim Poe. I'm Director of Telehealth with the UNC Cancer Network, and I want to welcome you to our telehealth lecture. This is our RN and Allied Health lecture, Caring for Older Adults with Cancer, Who, When, Where, Why, and How, with Dr. Trevor Jolly. So a few things to go over before we get started. We are going to be using polleverywhere, and we are very appreciative. Dr. Jolly has come up with a lot of different polls for the lecture today. So we want you to go ahead and get joined to the poll and then be ready to answer some different questions that will show up during the lecture. So first off, if you've never used polleverywhere, let me go over it very quickly. You can either on a web browser go to pollev.com/UNCCN, and you can do everything from there. Alternately, you can use any phone with texting capabilities, and you text to the number 22333, the letters UNCCN, and you do that just once. That will join you to the poll, and then you can go ahead and start responding to the different questions. Now, the question we'll have today is, to start us off, is in the U.S., what is the median age of patients receiving a cancer diagnosis? So if you think it's 76, you can put A. If you think it's 67, you can put B. If you think that's 52C or 48D. And then we'll have lots of these other A, B, C, D questions. So be ready for those as they occur during the lecture, and we'll look forward to seeing your responses, and Dr. Jolly can talk about those during the lecture. And then at the end, we'll have lots of time for questions and answers, and you can text in full questions via polleverywhere at that point. Dr. Trevor Jolly is an assistant professor in the UNC Department of Medicine, divisions of Geriatric Medicine and Hematology Oncology, and a care provider in the Geriatric Oncology Specialty Clinic. He earned his medical degree from the University of West Indies, Trinidad, and completed subspecialty training at the University of Alabama, Birmingham, and UNC Chapel Hill. Dr. Jolly is a 2010 and 2012 recipient of the Ruth L. Kirstein National Service Research Award, a current Hartford Center of Excellence in Geriatric Medicine Scholar, and a 2017 recipient of the UNCH and UNCFP Carolina Care Excellence Award. His research focuses on the value of geriatric assessment to guide interventions and treatment decisions in older adults with cancer. So, Dr. Jolly, welcome.
Thank you. Thank you for such a great introduction, Tim. It's a pleasure to be here.
Thank you for being here. We really appreciate that. Maybe before we jump into the lecture, if you could tell our audience a little bit about what led you to the field of oncology and specifically geriatric oncology.
So you mean, besides the fact that it's probably one of the most rewarding populations to work with, I grew up with my grandmother, from a very young age, I spent quite a bit of time with older adults, and you don't get to be 70, 80, 90 years old just like that. It's really life experience, and sitting with them and listening to their stories and their experiences and just learning from them actually is actually very rewarding.
Great. Great. Well, we're fortunate that you chose this field.
Good.
It looks like we're trending on our poll here.
That's very interesting. So we'll talk a little bit about that, but no surprise that D looks like is the most popular answer. So, all right.
Okay, good. Well, I'll turn this over to you. Again, a reminder for our audience, if you can try to be ready for those poll questions, and that way we don't have to delay too long on any one question. So as soon as you see the questions, go ahead and put in what you feel is the answer. Of course, this is all anonymous, and then Dr. Jolly can respond to this.
Good. Well, thank you once again, and I really appreciate the opportunity to speak here today at the UNC Cancer Network session. I'm going to talk briefly today about caring for older adults with cancer, a topic that is near and dear to my heart. As Tim mentioned, I am an assistant professor in the Division of Geriatric Medicine and have a joint appointment in Hematology Oncology. And I'm also one of two providers along with Dr. Hyman Muss in the UNC Geriatric Oncology Specialty Clinic. So a brief outline of what we're going to be talking about today. I'm just going to briefly go over what is geriatric oncology. Usually when I tell this to people, a lot of them ask me, what is really geriatric oncology? And the first question I usually get is, well, you're not really old enough to be a geriatric oncologist. But I'm not a geriatric oncologist. I'm a geriatric oncologist. We're going to talk briefly about the demographics of cancer and aging, the heterogeneity of aging, and how we assess older adults. And then we'll go through in a practical way some geriatric assessment tools that you can actually use in routine clinical practice. And if there's time at the end, we'll take some questions. So let me start off by just defining what geriatric oncology is. This is a consensus statement that was made back in I think, 96. It is a multi-dimensional, multidisciplinary field born out of the need to train academic specialists to respond to the substantial challenges and opportunities in prevention, early detection, diagnosis, and management of cancer in older adults. But simply put, really, geriatric oncology is the implementation of geriatric principles in older cancer patients. And so why is this important? So here are the U.S. Population at varying time points. And as you can see from this graph, the U.S. population is aging. So currently, the most recent data that we have, approximately about 13% of the United States population is 65 years and older. If you flash forward to 2030, about 20% of the U.S. population is going to be 65 and older. That's a substantial increase in the number of older adults. And if you don't believe it's true, here are population estimates for North Carolina for patients over 65. Here represented in red in various counties are the counties where more than 16% of the population was 65 and older. This was census data from 2000. And if you flash forward to 2030, this is what the map is going to look like. So the U.S. population is aging nationwide, and certainly is in North Carolina. And so why is that an issue? And so if you look at the cancer and aging, there is a very marked association between cancer and aging. As a matter of fact, age is the single most important risk factor for developing cancer. So here are the age-specific cancer incidence rates, the age-specific cancer incidence rates, so that the number of new cases per 100,000 back in the year 2000. And you can see here among males, men, and women, the incidence of cancer rises dramatically, beginning in the early 50s, and certainly peaks by the time you're 70 and 80, more so in men than in women. And it was interesting that that initial poll found those results because if you look at the television, you wouldn't really know it. Usually, cancer patients are often are portrayed as being younger and kind of healthier, but the actual median age of a cancer diagnosis in the United States is 67. And the reason for that is because it takes a long time for these genetic abnormalities to accumulate to the point where enough DNA is damaged and genes go bad to develop cancer. And so the majority of cancer patients are actually older. This is the population that is probably most at risk of cancer. And why is that? So here again are a different way of portraying this data. So here are the cancer incidence rates by age projected from 2000 to 2030, and you can see over that interval the incidence rates of cancer rises dramatically. But if you dig down and drill down a little bit deeper into this data, you will say that the majority of the increase in the incidence rates of cancer is going to be in the older adult population, those 65 and older, whereas those under 65, the growth remains pretty much flat. Here's another way of looking at it. So these, again, are projections between 2010 and 2030, and these are percentages. So the percentage increase is going to be pretty much in the older adults population, those over 65, whereas the younger adult population pretty much remains flat. And a major problem with this association of cancer and aging is that older adults really have not benefited as much from modern therapies as have younger cancer patients. So here on this graph are the cancer mortality or the death rates by age prior to the onset of modern chemotherapy and after. And so you can see here that for younger patients, the death rates have actually gone down substantially beginning around 1995 or so, even for those, 20 to 49, 50 to 64, 65 to 74. But for those 75 and older, the decline in mortality rate is less pronounced. In addition to that, despite the fact that the mortality rates for older cancer patients tend to be higher than for younger cancer patients, we're actually still doing pretty well and are able to treat appropriately and cure some curable cancers in older adults. And what that results in is a number of older cancer survivors. And so here in this graph are cancer survivorship and age. Here represented are people who are living up to 15 years after their diagnosis and treatments. And you can see that across the spectrum, the number of older cancer survivors is increasing, so that by 2020, there are going to be an additional 18 million cancer survivors projected. And that has important workforce implications, because who is going to care for those older cancer survivors? So here are the projected future needs for geriatrician, and this graph is fairly depressing, because at present there is about one geriatrician for about every 2,620 older adults in the United States. These are the most recent estimates for 2013. Flash forward to 2030, if you were to keep a fairly similar, although not quite, ratio, maybe 1.5 times what it is currently now, so one geriatrician to 3,798 older adults, you would require an additional 30,000 geriatricians. At the current rate of training of about 200 a year, we're probably not going to make it. So that is going to be an interesting scenario. So a few important points here. So cancer is a disease that is strongly associated with age. The U.S. population is aging. The majority of cancer incidence and mortality occurs in older adults. The number of older cancer patients, the absolute number of older cancer patients is going to increase. And really there is not enough geriatricians to assess older patients, so we'll all have to learn, all healthcare providers and ancillary staff, including nurses and support staff, will need to learn how to assess and care for older cancer patients. So I'm going to switch gears here a little bit and talk about the heterogeneity of aging. So looking at these pictures here, it could be theoretically possible that all of the people on this slide are the same age. And that is a concept that it really needs to be understood. I mean, people have said that age is just a number, and indeed, when you're dealing with older adults in the geriatric field and in geriatric oncology, that seems to be borne out. The reason why is because all of our organ reserve is diminishing. So as we get older, everything from our cellular water, kidney blood flow, maximal breathing capacity, nerve conduction velocity, cardiac output, everything diminishing. And my boss, Hyman Moss, likes to say that we are disintegrating over time, beginning from about 30 to 80s. All of our organ functions and reserve capacity diminishes. And these decreases in organ functions are not always obvious. So many of them are occult. So here on the left side of the screen is the maximal heart rate, and I've went in and calculated the maximal heart rate at different ages. So here's your maximal heart rate at age 20. If you use this formula, it's almost 200, whereas by the time you get to 80 years old, it's about 150. And why that is important is because we will frequently see a patient in the emergency room or somewhere elsewhere in the healthcare facilities, even in the clinic, and they are running a heart rate pulse of near 98, 100. And if that patient is younger, they're doing just barely half of their maximal heart rate. But if that patient is older, in their 80s and 90s, they're pretty much running a marathon. They're almost 2/3 or even more of their maximal heart rate. Likewise, here on the right is the creatinine measure and the creatinine clearance, or your measure of your renal function at various ages. So if you look at age 60, which is what is considered our institutional norm, a creatinine of 1.4, your GFR is pretty normal. Whereas by the time you get to 90, the same creatinine value results in almost having significant renal impairment to the point of requiring something like dialysis. And that has important implications for drug dosing and so forth. And unfortunately, a lot of these deficits are not recognized, frequently not recognized. Another result of this diminished organ function is the development of comorbidity. So you can imagine if your cardiac function diminishes over time, that your heart function as a whole is going to diminish, and that's eventually going to lead to heart failure. Likewise, brain function, dementia, endocrine function, diabetes, cardiovascular function, hypertension. And so you can see from these graphs that as we get older, all comorbidities, and indeed severe comorbidities, increase with age, with the exception of HIV, and that it also, from recent data, might be also changing. So you have a population of people who are getting older. They also tend to have more comorbidities, and that also impacts your treatments and outcomes when you're managing a patient with cancer. So here are the upper, middle, and lower quartiles of life expectancies for women. The men are not included in the slide, showing that at various ages, the upper, lower, and medial quartiles of life expectancy actually differ based on your health status. And so if you are 70 years old and in good health, like perhaps this woman who's doing the handstands here that I can't do, you have an additional 20 years of estimated life expectancy. Whereas if you're in not so good health, your life expectancy is diminished and down to about 9.5 years. And the same is true at pretty much all ages. Typically in cancer medicine, we use a 5-year estimated survival to determine in the adjuvant setting if it would be appropriate to give things like chemotherapy. And so you can see here, if you're 85 years old, although there's limited data for giving chemotherapy at 85 years old, or even 80 years old, that can have dramatic implications for your treatment decisions. If you're in good health and having a 13-year estimated life expectancy, or not so good health when it falls to less than 5, or even as low as 3 years, where other options for care, like supportive or palliative care, might be more reasonable. And hats off to the pediatricians because they have noticed this heterogeneity long before we did in the pediatric population. So here is different milestones for development. So children at 6 months, 12 months, 18 months, 2 years, 3 years, 4 years. And a concept that is key in pediatrics is that functional age is closely linked to chronological age. So if you have a child at 6 months or 12 months who is not doing certain things, then that's a key to the provider that something might be wrong. Whereas in older adults, that may not be true. In older adults, functional age and chronological age frequently differ. And so, again, along the aging spectrum, the pediatricians have recognized long before we did that these patients require unique providers with unique training and skill sets, that their patients have age-related changes in their physiology, that they're vulnerable to toxicities from the treatments that we prescribe, that they have dependencies in their activities of daily living, and then there are concerns about the long-term side effects of the therapy, like neuropathy that we give, that some patients can get when they have chemotherapy and so forth. And I would be willing to challenge anyone to tell me how that's any different in the geriatric population in 2017. So one important point here is that in older adults, chronological age is frequently not equivalent to functional age. And in addition to that, the perspectives of cancer and cancer treatments change with aging. So in younger adults, they tend to have a single medical condition. They don't have many comorbidities, and the cancer tends to dominate the clinical picture. They're able to tolerate acute stress and the side effects of our treatments relatively well. And the goal, for various reasons, because of family and children and so forth, tends to be survival and cure. Whereas in older adults, they tend to have multiple existing or coexisting comorbidities, and the cancer is just one of those. The cancer is often a competing cause of mortality. There are some patients who walk into our clinics with very small, for example, breast cancers that would never impact their survival, and who have underlying cardiac disease that have 50 or 60% mortality from their heart disease. And in that case, the cancer may not impact their overall outcome. They have variable tolerability to the specific treatments, and they require tailoring of their therapies because of their comorbidities and because of their risk of having these side effects. And frequently, the goal actually is different. So there are many older adults in whom their quality of life actually trumps longevity. They're more concerned about feeling good and enjoying whatever quality of life they have than living longer. And so a few more important points. It's important to assess if the patient is going to die of or with their cancer, because that's will determine what types of treatments are initiated. Is the patient going to live long enough to suffer the consequences of their cancer? Is the patient able to tolerate the treatment? Are there complications of treatments that are more common in older individuals? And does the patient have an adequate social support system to support them during these treatments? And so what really is the goal of treatment? And that can vary from cure to prolongation of active life expectancy, to effective symptom management, to comfort, or to first doing no harm. But this, to me, would be the ultimate goal of therapy if we can accomplish this in all of our patients. And so I'm going to switch gears and talk a little bit about how we assess some of our older patients in the clinic. And this is a concept that we published a few years back. It's called the Geriatric Oncology Iceberg. And here you see a serene scene, a very peaceful, serene scene with the tip of the iceberg here on top. And in the clinic, that usually represents the things that we can see. So as oncologists, we frequently consider the patient's age and this very crude measure of function called the performance status. And several publications, some of which I will show here, shows that it's probably not the best measure of functional status. We also consider the tumor characteristics, the size of the tumor, the number of lymph nodes involved, and things like organ function, so kidney function, cardiac function before we start our treatments. All of those are important. But what is missed by this traditional model of assessing older adults is a whole host of factors that underlie the surface, that are beneath the surface, that we're not always aware of. So polypharmacy, multiple medications that interact with each other and can actually interact with the chemotherapy that the patients that the patients receive. Medical comorbidities. We frequently say, well, go see your primary care provider to deal with those. And several times, patients will come back having seen their primary care providers, and again, still challenging to manage some of these problems because our therapies impact these comorbidities. Falls, we did a study here, and I'll show you some of these data showing that we're not very good at assessing patients with falls or even detecting them. Psychosocial dysfunction, the support the patient has, as we talked about. Molecular aging and sarcopenia are areas that we're actively researching. Nutritional and cognitive deficits, and certainly functional deficits. These are all kind of independent risk factors for poor outcomes in older cancer patients. And if they are not adequately addressed, can impact the overall outcome of the patient. So what is a geriatric assessment? So again, consensus statement was defined as a multidimensional, interdisciplinary patient evaluation that leads to identification of the patient's problems. The benefits of doing one is that it can uncover problems that are not detected by a routine history and physical. It can predict things like chemotherapy toxicity, morbidity, survival, and lead to interventions that improve function, nutrition, mental health, social support. And there's a growing body of evidence that it can actually improve outcomes such as early hospitalizations and survival in older cancer patients. The challenge is that it requires a full geriatric assessment, requires quite a bit of time and specialized personnel and expertise, and there are not, as I showed you, enough number of geriatricians to do them all. And so we really have to learn to do it ourselves. Here is an abbreviated measure that we use in our clinic. As you can see from this table, it is predominantly self-administered with a questionnaire. The only thing that we do is a timed up and go, get up from a chair, walk 10 feet, return and sit again, and a brief cognitive screening test, and usually the BMI is measured for us. In addition to that, there are all these self-reported measures of functional status, such as activities of daily living and instrumental activities of daily living, ability to get dressed, put your clothes on, go to the bathroom, ability to use public transport, manage your finances, drive, those kind of things. We also screen for falls. We look at comorbidities and brief measures of mental health and social function, and certainly weight loss. In clinical practice, it takes about 10 minutes of the provider's time. In some of our studies, it takes about 10 minutes of the provider's time and about 20 to 30 minutes of the patient's time, a lot more time than they spend usually waiting in the waiting room to get, to see their provider, or while they're waiting for their CT scans. These can be done. And so here are some of the data that we've generated from looking at this. In our clinic, this is a study that we published in the Oncologist, where patients and providers, 81%, so about 796 people in this particular database, agreed that their measure of their function, called the Karnofsky's performance status, that they were asymptomatic and had normal function. So these are people who said that they were normal, and that their provider or the clinical research associated who evaluated them agreed. And we found a number of functional deficits in these patients, ranging from poorer mental health, large number of polypharmacy, almost 40%, medical comorbidities, falls, decreased social activity, impairment of activities of daily living, weight loss, and not a lot with mental health problems, but significant number with functional deficits, unable to walk. Many of them had difficulty bathing, dressing, climbing stairs, or performing a vigorous activity. And the deficits were kind of across the board. The majority having none, but some of them also has 1, 2, 3, or as many as 5 or more deficits. This is another study that we did looking at screening for falls. So 528 patients in this very same database of geriatric assessment, and 24% of them, approximately 125, reported 1 or more falls. And then we looked at the chart to see if it was documented. Not many of them were, so less than about 10%. Not many of them had a gait assessment, so 20% had that, and that was usually in the form of a templated note. 17 of them had the recommended vitamin D testing, and that usually was for some other reason, like for bone health because they were on endocrine therapy. And only about 6% actually had referrals for interventions on their falls. And so now I'm going to kind of walk you through some practical ways that we use this geriatric assessment in our clinical practice. So this is going to be the first question for you. We have a 75-year-old woman with stage 3A, so relatively high risk of cancer. This is a large tumor, and it's involving the lymph nodes, so the risk that this cancer has spread elsewhere and could come back is fairly high. It's a grade 2 hormone receptor positive breast cancer. She's a never smoker. She has a BMI, body mass index of 30. She has no prior cancer, diabetes, or COPD. She's never been hospitalized in the past year. She believes that, or she self-rates her health as excellent, and she has no dependencies in instrumental activities of daily living. And she's able to walk a mile each day. And so when we give these treatments, we do it like chemotherapy in an effort to ensure that after this cancer is removed surgically, that it doesn't come back, and that we sterilize the body of all of these microscopic spots of cancer that may have left the primary tumor and spread past the lymph nodes to other sites in the body, like the lung, the liver, and the bones. So the question for you is, considering all of this information, what is her estimated life expectancy? If you forget about the breast cancer diagnosis and just look at this patient, walked into your clinic, the same age, what would be her risk, her estimated life expectancy?
All right. And again, if you've already joined the Poll Everywhere poll, which we hope you have, then you can just send A, B, C, or D, and we should start seeing those up on the screen in just a moment. Okay, got a vote for D.
All right, so it says 50%. All right. And so...
Getting more votes in.
Yeah, this is interesting.
Trending with D, but we've got the strong C right behind there.
That's interesting.
Yeah.
Should we give it another?
Another couple of seconds, and then let's go ahead and let them know.
I think most people are kind of half split between C and D.
Okay.
All right. Well, the good thing about this is that you really don't have to guess. So I'm sorry we put you through that poll. But they're actually helpful tools, and one of the best ones I think is called ePrognosis. So this is a website you can all go and check it out, and this is the bubble view, which I really like. Each one of these is a tool that estimates life expectancy, and the size of the bubble represents how many patients the study was validated in. And there are different settings like outpatient, inpatient, and so forth. And it estimates the likelihood of survival, without the cancer, just somebody walking in if they didn't. Oops, just go back here. There's more people voting. Without the cancer, it uses some geriatric assessment data. It's easy to use, and there are several scales, as I mentioned. And so I've taken the liberty of going to put in all of this data for you: age, sex, smoking history, and here are the geriatric assessment variables: hospitalization in the past 12 months, self-rated health, dependencies, and instrumental activities of daily living, and ability to walk a few blocks. And here is the data put in, and so her mortality risk, as nobody really guessed, it sounds like, is actually quite low, because this is a woman who is very healthy. She has a high-risk breast cancer, but if you just look at her and you not consider the breast cancer, her pre-morbid state is pretty good. She doesn't have a lot of comorbidities, still able to walk, she's still doing all her activities of daily living, and really functioning well. So the actual answer was closer to about 15%. So let's go on to the next question. So I think I missed it there. I think the question is not showing up for me. Oh, here's the question. So now, if you consider her risk with the cancer, what is the probability that she will be alive? And I think this is where the confusion started, that a lot of people were considering the breast cancer. So now let's consider the breast cancer, this very high risk, aggressive breast cancer. What is the chances that with no treatment that this woman, or with various treatments, would be alive in 10 years.
All right. And again, if you haven't already joined our Poll Everywhere polling, you can do that by going to pollev.com /UNCCN, and it's easy to do on any smartphone or computer. And otherwise, if you still want to join and haven't yet, you can text the number 22333 with the letters UNCCN one time. That joins you, and then you can put in this case, A, B, C, or D for your response corresponding with the different answers on that you see in front of you there.
All right. I think, again, there's a split between C and D here, with most people choosing C. So again, you don't have to guess. So this is another tool that we use. Unfortunately, this one is actually down while they're updating the data. This tool is called Adjuvant Online. And so here I went in and took the liberty of putting in the age. I like this tool because it also includes a measure of their health status. And as we said, this woman is pretty much, although she's 75, the picture of health. I put in all her tumor characteristics that we talked about, and here is the result. So if you look at people like this patient who received no additional therapy, about half of them will be alive in 10 years. But 30%, like many of you said, would actually succumb to their cancer without additional treatment. And then this is another interesting feature, another unique feature of Adjuvant Online. If you look at the benefit of treatment represented here in yellow, it's estimated that just with hormonal therapy, you cut that risk of dying from breast cancer by about 8%. And if you use both chemotherapy and hormonal therapy, you cut it by about 13%, almost in half. And so, and so the majority of you actually were right, that she has about a 30% risk. So overall, in summary, she's in good general health. She has a reasonable life expectancy. A breast cancer diagnosis would not likely impact her survival, and combination chemo and endocrine therapy is expected to provide a survival benefit. And so, based on her goals and values, you would probably, if she were okay with it, recommend for such treatments. And here is the second question that we're going to poll you on. So this is a 75-year-old man, same age, a different cancer, again, smaller size, but has lymph nodes, so fairly high risk cancer, same phenotype, grade 1 colon cancer. He currently smokes. His body mass index is 19. He has diabetes and COPD. He's had one hospitalization in the past year for his COPD. He self-rates his health as fair. He cannot shop for groceries, and he can barely make it to the mailbox down the hall. And so, considering only the patient, forgetting about the cancer, a very frail gentleman, not in quite good health, still smoking, can barely walk to the mailbox, what is his estimated life expectancy? Is he going to live for a very long time or a very short time? What is his approximate 10-year, 9-year mortality? It's probably going to be very high. Some people are starting to respond here. I'm sorry I gave you guys a hint. But how long we wait?
Let's give them a few more seconds. Again, we really appreciate your taking the time and effort to respond to these.
Many people are, I don't know if you can change your mind here, but some people are changing their mind, it looks like.
Well, I think that just, as we get additional responses, that changes the percentile.
So far we have 75% polling in saying that his estimated life 10-year life expectancy is about 90%. I don't know if I really asked that question the right way.
All right, you want to give it to them?
All right. Well, again, you don't have to guess. I went in and put in the data here, and so here it is. And so the risk of him dying, as most people I believe said, was about 90%, because he has a lot of other medical comorbidities and is very frail and has very poor function, and also even self-rates. He recognizes this and self-rates himself poorly. So these are useful tools. And then now, considering his cancer, I think I did not get that one, yeah. Now, considering his cancer, if you put the cancer in there, what is his mortality risk if you consider the colorectal cancer in 10 years? What is his chances of dying from colorectal cancer, in other words? Is it high risk that he will die from colorectal cancer, or is it a low risk that he will die from colorectal cancer, given that he has sounds like, advanced COPD?
All right, so there we go. We're getting those responses in.
Oh, it's interesting. Ah, it's pretty fascinating to see this in real time.
Yeah, yeah.
So maybe in the next few seconds here, but it looks like it's close, essentially a 50-50 split between about 33% and about 18%. So that's interesting to see. But again, recall that this is a gentleman with a lot of health issues, and he has advanced COPD. It sounds like he's already been hospitalized. He has a significant competing cause of his comorbidity. He has fairly advanced cancer, but he has fairly advanced lung disease. And so, again, don't have to guess. Put his information into the adjuvant model. So here's his age, the tumor, the number of lymph nodes, and you can see here on the left that the majority of patients like him actually don't succumb to their cancer. The majority of them succumb, 77% of them succumb to other causes. And you can see here that only about 7% of them succumb to their cancer. And if we give additional treatments to try to reduce that risk, it's not very helpful. Only about 1% of them benefit from chemotherapy, and the reason is because the majority of them actually succumb to their other problems. And for this particular patient, he probably, and this is theoretical, but probably succumbed to his underlying COPD. And that's the challenge. I think that's the struggle that you're experiencing, what we experience every day in the clinic. You know, how do you determine what is the major comorbidity? What is the major competitor, the major competing comorbidity? And in addition to that, there are actually other tools that we can use, for example, to assess the risk of chemotherapy. And so here is a study that was done by Huria, and that showed, in addition to the traditional risk factors for receiving chemotherapy, like age, polypharmacy, standard versus reduced dose, and so forth, hemoglobin, creatinine, that there were actually geriatric assessment variables like your ability to walk, block, falls, hearing impairment, and assistance required in taking medicines, and decreased social activity that actually predicted chemotherapy toxicity. And so these are the actual odds ratios that were converted into a score, and you can add those score up based on which of those variables you had, and you can see that there's an increase in the risk of chemotherapy toxicity with increasing score. So the more of these geriatric assessment variables that you have, presumably the higher your risk of having side effects from the treatments that we frequently prescribe to treat cancer. And so putting the second patient together, in summary, he's in overall poor general health. He has significant competing causes of morbidity and mortality. He has a limited life expectancy. His colorectal cancer would likely not impact his survival. His adjuvant chemotherapy is estimated to provide a very modest 1% benefit in survival, and he has substantial risk of toxicity if you went back and plugged in those variables. And so if it were consistent with his goals and values, you would probably recommend against adjuvant treatments for this patient. And so just putting it all together in the last few slides here, if there is benefit a likelihood of benefit for cancer-directed therapy, then you would probably recommend it. If there was no likelihood of harm, you would recommend against it. But in between, you would have the patient's values and preferences and wishes as the fulcrum that helps to decide which way you make that decision. And so a few important points on the last few slides. There are tools that are available that can identify older adults at risk, that can predict toxicity in cancer patients, that can predict survival in older cancer patients, that can uncover or help detect problems that are not routinely addressed or detected in a routine H&P, and that can guide practical interventions that we hope will improve outcomes in older cancer patients. And then on a more personal note, I wanted to share this case, which is actually based on a real patient that comes to our clinic. She's a 75-year-old woman. She has a history of diabetes, high blood pressure, and she presents with worsening shortness of breath and is found to have critical aortic stenosis and narrowing of the valves in her heart. She is limited in several of the IADLs, instrumental activities of daily living. She required a son to help her, with transport and cooking and cleaning and management of her medicines. Her performance status, which is the screwed measure, is 2. On exam, she was found to have a large left breast mass and also a thyroid mass. She had a scan of her whole body, which showed that the left breast mass was really, and some lymph nodes in the armpit were really the only site of involvement. There was no evidence of spread elsewhere outside of that area. The breast mass was biopsied, and it turned out to be a hormone receptor positive breast cancer, so a hormone sensitive tumor. These are tumors that people can live with for very long periods of time with endocrine therapy. She had thyroid biopsy or needle biopsy to the thyroid that was suspicious for follicular neoplasm. She had a cardiac catheterization where they put the little tube in and shoot some dye into your heart. It showed that she had the severe valve narrowing of the aorta and some of the pulmonary valve as well, but no significant coronary artery disease. And she had adequate heart function, so her heart was actually pumping pretty well despite having significant stenosis. And so this was a challenging case for me, because here you have a patient who's a little on the frail side, but has actually a fairly indolent type of breast cancer and a very severe form of heart disease. And so when we met with this patient for the first time, there was a lot of anxiety, which is understandable, and there was a lot of concern about the cancer. And I think they were even a little underwhelmed during the first visit by my concern for the cancer. I was more concerned about her aortic stenosis. And so I would like to poll the group and see what other people think would have been the right answers, things to do. Should we have gone and subjected her to surgery, remove the thyroid gland, remove the lymph nodes in the neck? Should we have gone after the breast mass and the lymph nodes? So the thyroid would have been for that follicular neoplasm in her neck, which again is another type of indolent cancer, not even clear if it is a cancer. This was an FNA. Should we have done surgery to her heart and fixed that first? Or should we perhaps have put her on hormone blocking therapy, since her cancer was hormone sensitive, and then non-invasively address her valve? Or should we have just blasted her with some chemotherapy and radiation and see what happens? So interesting to see what happens here. I think most people are kind of thinking along the same trend here. Because I think 100%. So far, the poll group have D. Probably give another minute. Any other takers?
All right, there we go.
Yeah. So, well, that's actually what we did with this particular patient. We actually, the majority, if you identify, we put her on hormonal therapy, hormonal blocking therapy, and now the breast mass is almost gone. She had her valve replaced and has been doing well almost 2 years after the valve has been replaced, still with her breast cancer in her body, still responding well to the treatments. It continues to shrink. The cauliflower-like portion has dropped off, and now the breast is almost starting to look more normal. And the thyroid lesion is still there, and it's still fairly indolent. But we have her heart valve fixed, and now her cardiac function is being optimized to the point where in the very near future, we might actually be considering surgery on her thyroid and then subsequently her breast. So this is just the last slide here, and to show kind of a general outline of how we think about these patients when they come to our clinic. The first thing we do is review the goals of care. We perform a brief geriatric assessment to help us estimate their life expectancy. If their life expectancy is low, the average life expectancy is less than 5 years, and they have multiple unmodifiable geriatric assessment deficits, in which case they would be considered frail. We consider things like primary endocrine therapy, like the last patient where we put them on hormonal blockers if they had a breast cancer that was responsive, or really some of these patients are not appropriate for cancer-directed therapy, and after discussion consider things like palliative and supportive care, whereas if they have average life expectancy between 5 to 10 years and unmodifiable geriatric assessment deficits, in which case they're considered vulnerable, we consider things like adapting or omitting chemotherapy and treating with endocrine therapies or other less aggressive therapies. If they have modifiable deficits, we address those deficits and see if we can get them back to baseline or back to normal to the point where they can have standard of care therapy. And if they have a good life expectancy, regardless of their age, if they're fit and if they are willing to, if it's consistent with their goals, then there's no good reason to be ageist and avoid giving these patients standard of care therapy. And so with that, I think we close. Thank you.
All right. Thank you. So what we'll do is we're going to see if our audience has any questions. So this is just the open-ended question form. You can go ahead and text in any questions you have for Dr. Jolly. I'll start with one while we're waiting for our audience to text in questions. So talk about the role of a team, if you would. With any cancer care, we know that there are tremendous benefits to the team approach. But is this even more emphasized with an older population, given all the different comorbidities, et cetera, that you've described here?
So absolutely, I think it's actually essential to have a multidisciplinary group. So at UNC, we're very fortunate to have the multidisciplinary, in what I do most, the breast oncology group. And, because of the aging populations, and the lack of really having adequate numbers of oncologists and certainly geriatricians to care for these people, then really a team approach is absolutely critical. I mean, there's no way that in the future, and my guess is that we're going to be able to care for all of these people, and we're going to have to incorporate nurses and allied health professionals to help us care for these aging cancer patients and cancer survivors. It's really going to be key.
Thank you. All right, we've got a question. Please briefly describe the difference between the two website tools that you suggested.
So there were actually, so there are a few tools that we discussed. So the first one really helps you just estimate life expectancy for any patient, regardless of the cancer diagnosis. As I said, there are different settings. So that gives us a sense of, how people would do if they didn't have a cancer. And that's important to know because you really want to know if their premorbid condition or is the premorbid life expectancy is good enough that if you were going to treat them with adjuvant therapies, that they would really have an adequate life expectancy to benefit from those therapies. So in general, if you have less than a 5-year life expectancy, the benefits of some of the treatments that we use are probably very modest. And so it'd probably be best to avoid some of them or choose alternative therapies. The second tool estimates the risk with the cancer itself.
Right.
So one looks kind of at your body in more general terms, in terms of life expectancy, and the other specifically address the cancer. I don't know if that helps.
And would these tools, would these be tools that you would actually show the patients the results of these, and what are their reactions tend to be?
So I think in most cases when I do these in the clinic routinely, and I will print the results out, or I will actually sit there with the patient and do it in real time. And I think that these tools are very helpful to help patients understand the absolute benefit of some of the therapies that we prescribe, and the risk that they have to undergo, and it helps them to make the decision. So frequently we have people coming in who really are wanting kind of more aggressive therapies for cancers that probably don't require such aggressive therapies. And when you show them these data and the limited and modest benefits, then some of them will actually understand why you don't recommend those therapies. On the other hand, there are people who have very aggressive malignancies and are concerned about their ability to tolerate the treatments. And these tools help to show them that their risk is higher than an average person, and that their life expectancy is good, and their comorbidities are not so bad, and it wouldn't be unreasonable to consider some of these treatments.
Sure, that makes a lot of sense, especially as you're trying to balance these quality of life decisions.
It's very challenging. So I hope that today we're able to show that that everyone can do this, and it's really possible.
Good. Well, we have a thank you there, and I want to echo that thank you, and I'm sure a lot of our audience does as well. I want to also say thank you to the North Carolina General Assembly for their generous support of the University Cancer Research Fund, or UCRF, and UNC Lineberger. We want to thank our team, Mary King, Veneranda Obore, and Alan Brown, for all the work they do to make this possible. We have more lectures coming up, always. July 26th, we have a Med-Surg lecture, New Options for Immunotherapy, Where We Are and Where We're Going, with Dr. Vincent. On July 28th, we have a community lunch and learn, prostate cancer, what to expect along the journey, with Mary Dunn. And then on August 9th, an RN and Allied Health lecture, Pesticide Protective Behavior in Agriculture, a cancer prevention strategy, with Dr. Walton. So we'll look forward to all of those lectures. We hope that you'll be able to attend, some or all of them. And of course, you can go to our website, unccn.org, and you can find out about all the events we have coming up. You can watch the lectures that have been recorded. We record each lecture and make that freely and widely available on our lecture library. You can sign up for our newsletter. If you don't receive our newsletter, we encourage you to sign up for that. Just go to unccn at unc.edu and let us know you'd like to be added to our newsletter, and we'll certainly do that. We've got, you can find us on Facebook, like us there, follow us there, find us on Twitter, find us on YouTube, lots of places to find us. We thank you for participating today. We look forward to seeing you at future events. Hope you have a great afternoon. Thanks so much.
Thank you.
Thank you, Dr. Jolly.